So someone asked us about the neuro-ophthalmology and treatment of pituitary adenoma. Obviously, that's a very big topic, but I think what they meant to ask me was, what makes you do something quickly versus slowly in a pituitary adenoma? And one of the things is the timing. So if it's acute, you have to worry about apoplexy. And so that's going to present with headache, loss of vision, either unilateral, bilateral, or the classic of bitemporal hemianopsia. And the headache's usually very severe and often is the worst headache of your life. And the reason you need to admit that to the hospital is apoplexy is an emergency. You kind of need your pituitary gland, and the hormone that you need acutely is cortisol. So you can kind of do without some of these other hormones, but apoplexy and low cortisol is potentially life-threatening. So they're going to be admitted, get the steroids, the imaging study, it shows the hemorrhage or necrosis, and in a pregnant lady, that's called the Sheehan syndrome. If it's subacute or chronic, you have a little bit more time, especially if it's chronic. That normally presents with painless progressive bitemporal hemianopsia, but it can be anterior and cause an optic neuropathy, either unilateral or bilateral, or if it's at the junction of the optic nerve and chiasm, that produces the junctional scotoma, or the junctional scotoma of Traquair, and you can watch the videos on that, or if it's compressing the tract, it causes homonymous hemianopsia. So these patients usually have transsphenoidal surgery in their future. And so you're going to defer, of course, to neurosurgery on the approach, but typically they're going to get a transsphenoidal surgery. And the determining factor on whether they can get a gross total resection or not is often the size of the lesion, but also the extension into the cavernous sinus. So once it extends into the cavernous sinus, that's the efferent presentations of the pituitary adenoma. As you know, the sella is right in the middle between the cavernous sinus, and so if it goes laterally, it produces diplopia and ophthalmoplegia, third, fourth, fifth, sixth, Horner syndrome, or any combination of those. Once it gets into the cavernous sinus, it's going to be harder to resect it. And so if it's past the carotid midway, all the way on the other side of the carotid, that's going to require postoperative radiation therapy. So transsphenoidal for total resection is best. If you get a subtotal resection, or if the pathology is WHO grade 2 or worse, they might have to have radiation therapy. These are not decisions that ophthalmology or even neuro-ophthalmology is going to be making. So pituitary adenoma treatment, make sure it's not acute, and apoplexy, admit that to the hospital, give steroids, get the imaging. If it's subacute or chronic, you have a little bit more time, and we're going to leave it to neurosurgery to do the transsphenoidal. Depending on the extent of the lesion, the size, and the pathology, they may or may not need postoperative radiation therapy.